Hi, this is Dr. Devaji Rao, surgeon from Chennai, India. I am going to talk to you about the obstructive jaundice. Jaundice is defined as yellowish discoloration of body tissues due to excess of circulating bilirubin. Normal serum bilirubin levels range from 0.5 to 1 milligrams per cent. Jaundice is detected clinically when serum bilirubin levels go above 2 milligrams per cent. The discoloration is most evident in tissues abundant in elastic collagen tissue such as sclera, skin, oral cavity and undersurface of tongue. To understand jaundice, metabolism of the bilirubin needs to be understood. Bilirubin is a byproduct produced from heme by three routes. 90% is derived from mature red blood cells, 7% is derived from marrow compounds of red blood precursors and heme compounds in the liver. Unconjugated bilirubin in the bile reaches the liver transported by plasma proteins. In the liver, it is conjugated into bilirubin glucuronide as a water-soluble compound by glucuronic acid in the presence of glucuronidase. The conjugated bilirubin from the liver is excreted into the gut through the bile ducts. The conjugated bilirubin undergoes bacterial deconjugation in the colon to stercobilinogen. Stercobilinogen is partly reabsorbed to be excreted through the urine as urobilinogen and partly excreted in the feces as stercobilin. Prehepatic jaundice is a condition where jaundice is caused by prehepatic pathologies. That is, the liver is normal but there is excessive production of bilirubin due to excessive destruction of RBCs. This occurs due to diseases like hereditary spherocytosis, sickle cell anemia, thalassemia, acquired hemolytic anemia, septicemia, and certain drugs. Unconjugated bilirubinemia is also produced due to defective conjugation of bilirubin in the liver. The diseases are limited to the liver, like the viral hepatitis, cirrhosis, Gilbert's disease, and Crigler-Najjar syndrome. Once conjugated, the conjugated bilirubin reaches the gut through the bile and produces conjugated bilirubinemia. The causes are the intrahepatic and extrahepatic. The intrahepatic cholestasis, they cause no obstruction, no mechanical obstruction, and the common conditions are cirrhosis, chronic active hepatitis, Dubin-Johnson syndrome, hepatotoxic drugs, and primary biliary cirrhosis. Whereas the extrahepatic cholestatic jaundice is caused by mechanical obstruction of the bile flow, caused by stones in the biliary system, benign strictures of the biliary system, malignancy of the biliary system, the periampullary tumors, acute and chronic pancreatitis, and malignancy of the head of the pancreas. We should also understand the biliary anatomy. The biliary anatomy consists of the ductal system which drains the bile from the liver into the bowel. There are two hepatic ducts, the left and the right, and they join to form the common hepatic duct, which is joined by the cystic duct from the gallbladder to form the common bile duct. The common bile duct opens into the second part of the duodenum through the sphincter of Oddi, joined by the main pancreatic duct. The biliary obstruction can be caused by various pathologies. They are classified into extraluminal, intraluminal, and intramural. The extraluminal causes are the malignancies of the liver, metastatic lymph nodes, pancreatitis, malignancy of head of the pancreas, and periampullary carcinoma. The intraluminal causes are foreign bodies, parasites, and gallstones, which form the commonest cause. The intramural causes are congenital atresia, sclerosing cholangitis, benign strictures, and tumors of bile ducts. The causes can also be classified etiologically as congenital, traumatic, inflammatory, neoplastic, and metabolic and miscellaneous. The congenital causes are biliary atresia and choledochal cyst. The traumatic is traumatic strictures, inflammatory sclerosing cholangitis, neoplastic hepatocellular carcinoma, cholangiocarcinoma, periampullary carcinoma, carcinoma head of the pancreas, metastatic liver disease, metastatic lymph nodes. The metabolic and miscellaneous are the gallstones and parasitic diseases. How do we investigate a jaundiced patient? The first investigation to be done is the simple urine examination. Presence of bile salts in the urine indicates bilirubinuria and confirms the presence of jaundice. And at the same time, urobilinogen determination also has to be done, and the absence indicates obstructive jaundice and excess indicates hemolytic jaundice. After confirming the presence of jaundice through the urine examination, we start doing the biochemical parameters. The raised bilirubin levels in the blood indicate jaundice. At the same time, the raised levels of serum alkaline phosphatase indicates biliary obstruction, which is generally not seen in medical jaundice. The albumin globulin levels get reversed in hepatocellular damage. The transaminases are raised in hepatocellular damage of viral hepatitis and not to that level in obstructive jaundice. The hemoglobin levels have to be determined for the presence of anemia. Total and differential leukocyte count has to be done to find out about the infections. The ESR may be raised in infections and malignancies. Radiology forms a very important part in the investigations of jaundice patients. Plain X-rays are fairly useful but not very contributory, but they may show radio-opaque gallstones and some amount of hepatomegaly. Ultrasound of the abdomen may be useful in assessing the liver parenchyma for malignant deposits and cirrhosis, and biliary system, which may show the nature and level of obstruction of the biliary tree. This should be followed by the CT or the MRI scan, which will show the nature and level of obstruction of the biliary tree. A contrast study like the ERCP or the MRCP have to follow. The administration of radio-opaque dye into the biliary tree by ERCP, a procedure called endoscopic retrograde cholangiopancreatography, may identify the underlying cause like CBD stones or the ductal malignancies. MRCP has the advantage of being non-invasive with the same accuracy, but biopsies cannot be taken. PTC or the percutaneous transhepatic cholangiography is ideal for demonstrating an extrahepatic obstruction and also for stenting to relieve jaundice. Spyglass cholangiography to directly visualize and treat the cause. Transabdominal ultrasound is the first basic investigation in a jaundice patient, especially patient with surgical obstructive jaundice. Endoscopic ultrasound gives a better sensitivity and details, and this particular picture shows an endoscopic ultrasound which shows a CBD stone at its lower end with a dilated common bile duct. At the same time, the ultrasound is useful to delineate the liver parenchyma and the lymph nodes around the liver in the porta hepatis, and the second picture shows there the metastatic lymph nodes in the porta hepatis. The next investigation would be a computerized tomogram or an MRI. These are used to look at the parenchyma and the structures in and around the liver. The first picture here shows the dilated biliary radicals in the biliary atresia. The second one shows the choledochal cyst. The left picture on the left side shows stones in the gallbladder and also in the common bile duct. The picture on the right side below shows a periampullary carcinoma. The next investigation would be the contrast enhanced photographs like the MRCP or the magnetic resonance cholangiopancreatogram or the endoscopic retrograde cholangiopancreatogram. The first picture shows a periampullary carcinoma, an MRCP picture. The second one is also an MRCP picture which shows a cholangiocarcinoma, and the third picture is an ERCP which shows a cholangiocarcinoma. The differentiation between an MRCP picture and the ERCP picture is the ERCP picture shows the presence of the endoscope, whereas the endoscope is not seen in an MRCP picture, and that's the way they are differentiated. Gastrointestinal endoscopies may be required as part of the investigative procedures in a jaundice patient. The upper gastrointestinal endoscopy is important to identify the upper GI causes, especially the malignancies like the periampullary carcinoma. The total colonoscopy may be needed to eliminate primary colorectal cancer metastasizing to the liver, producing obstructive jaundice. Ultimately, where possible, histopathology and biopsy is most important, and the biopsy of the liver can be taken percutaneously or CT guided. Do not forget to do the coagulation profile, and also the prolonged prothrombin time is an accompaniment of a deranged liver function test and needs correction with vitamin K. Stool examination may be needed for bile pigment, the absence of which indicates obstructive jaundice and excess amount indicates hemolytic jaundice. The positive occult blood suggests a gastrointestinal malignancy or a bleeding esophageal varices. This particular table shows the differences between medical and surgical jaundice. Abdominal pain is generally absent or mild in medical jaundice. Maybe it is severe in surgical jaundice. The jaundice is high to start with in medical jaundice, but it becomes progressive in surgical jaundice. When it comes to investigations, the urine, bile salts and bile pigments are present in both types of jaundice. Urobilinogen is present in medical jaundice, absent in surgical jaundice. Serum bilirubin levels, the total bilirubin levels are raised. Indirect is raised in medical jaundice, the direct is raised in surgical jaundice. Serum alkaline phosphatase generally remains within normal limits in medical jaundice, whereas it is raised in surgical jaundice. The enzymes, the SGOT and SGPT, are markedly raised in medical jaundice, but in the surgical jaundice they may be normal or they may show a very mild rise. The ultrasonography is generally normal in medical jaundice, but it shows dilated biliary radicals due to an obstruction in surgical jaundice. The radiology is generally not required in medical jaundice, but in surgical jaundice the ERCP, MRCP, CT or MRI may be needed depending on the situation. The viral markers profile is definitely required in medical jaundice, whereas the HBsAg alone is required in surgical jaundice. The other markers may be required in medical jaundice, but generally nothing more is required in surgical jaundice. Here you see the algorithm in the diagnosis and management of a jaundice patient. A jaundice patient means a patient who has got increased levels of bilirubin in the blood. First thing we'll have to identify is whether this is an unconjugated bilirubinemia or a conjugated bilirubinemia. Patients with unconjugated bilirubinemia will have increased amounts of urobilinogen, whereas patients with conjugated bilirubinemia will not have urobilinogen in the urine. Following this, a clinical examination has to be done to find out these following details. If the liver is enlarged or which is normal, then it is a medical jaundice. In medical jaundice, the liver enlargement is mildly tender and smooth, whereas in surgical jaundice, the liver may be firm to hard, nodular, non-tender, and the gallbladder may be palpable, associated with the abdominal lumps. Following this, the first investigation to be done is the transabdominal ultrasound of the abdomen to find out about the dilated biliary radicals. If there are no biliary radicals, dilated biliary radicals, and the ultrasonography is normal, then the diagnosis is medical jaundice. Whereas if you find dilated biliary radicals, then this is due to an obstruction, and the nature of obstruction and the level of obstruction have to be identified by further examinations. The radiological examinations are the investigations which will delineate the biliary system, that is the MRCP or the ERCP. MRCP is generally non-invasive, and that is preferred to ERCP. After which you find whether there is an obstruction, and then once there is an obstruction is found, you call this as surgical obstructive jaundice. Once you have made a diagnosis of the obstruction, the question is to treat, whether it is operable or not operable. The common causes are the stones, strictures and tumors. If they are operable, the stones have to be removed by the ERCP sphincterotomy, basketing or lithotomy, or the open choledochotomy. The benign strictures can be resected or bypass procedures can be done. and connecting it to the bowel. The resectable tumors have to be curatively resected or the curative surgery has to be performed. Unresectable tumors will have a palliative resections. In patients who have strictures which cannot be anastomosed to the bowel, the ERCP stenting or the PTC drainage are the procedures of choice. Here you see how a sphincterotomy and stone extraction are done. Sphincterotomy is done using a sphincterotome which is passed through a side viewing gastroscope. The sphincterotome is passed through the sphincter of body into the biliary tree and the sphincter is cut and the sphincterotomy is done. After doing the sphincterotomy, a balloon catheter is passed into the biliary tree, that is into the common bile duct beyond the stone, and the balloon is inflated and the catheter is pulled out. As the catheter is pulled out, the stones also come out into the second part of the duodenum and they spill into the intestinal cavity. When the basketing is done, the Dormia basket is passed into the common bile duct. The basket is opened, the basket catches the stone and the basket is given a twist to cut the stone or hold the stone, and that is extracted and the stone again is dropped into the second part of the duodenum. Thank you very much for watching.